Our next lecture is going to be on stroke, 24-hour protocols, by Dr. Angela Carrick. Dr. Angela Carrick has no disclosures to make in regards to this program. And Dr. Carrick is board certified in emergency medicine. She's a board certified emergency physician. She graduated from the Kansas City University of Medicine and Biosciences in 2005. And she completed her emergency medicine residency at Integra Southwest Medical Center in 2009 and has been attending for the Norman Regional Health System since that time. She and her husband, Robert, a Norman firefighter, has 3 boys, and they enjoy spending time together as a family. Professionally, she serves as Associate Program Director of the Emergency Medicine Residency in Norman and is co-director of the Stroke Committee. Dr. Carrick.
Thank you so much. Thank you guys for having me today. I'm very excited to talk about stroke. This has become somewhat of a passion and sort of my thing in serving as our co-director of our stroke program. I get to review a whole lot of cases of stroke patients, and so I get a lot of questions about what should we do, or what would you do, or what's the protocol on this? So through all of those questions, I've sort of come up with some tough questions that I think that are common and hard to answer that I wanted to talk about today. Currently, only 5% of patients that are eligible for thrombolytics get them. And this is too low. There's several reasons for that. One is the huge list of contraindications that I'm sure all of you have posted somewhere or look at when you get a stroke patient. And when I say contraindications, I'm referring to IV-TPA in your acute ischemic stroke patient. So it's not only a long list, but it's been changing over the past several years. And so it's hard to remember what is the current protocol, what is the current exclusion or relative exclusion, and it almost sometimes seems overwhelming, as if, there's just too many. It's too much, it's too hard, I don't know. So I want you to feel comfortable with the list. I want you to feel comfortable answering these questions, and hopefully we'll go over some things that will help you know what to do in your next stroke case. So these are a list of objectives, but really what I'm gonna do today is walk through 3 real patients. These are Norman patients. They're what I classify as tough cases for one reason or another, which you'll see. And ultimately, all of them did receive treatment with either IV-TPA or thrombectomy or both. And so we're going to talk about the inclusion and exclusion criteria, the updated guidelines, what those are. We're going to talk about how to risk stratify patients for IV-TPA, because all patients are not created equal. We know that. So there's some patients that are riskier than others, but how do we know who that is and who's safe to get it and who's not? And lastly, I'm going to talk about specifically mild and rapidly improving symptoms in those patients and what to do with those. So this is our first case. We have a 94-year-old gentleman. He has some right-sided weakness, some facial droop, and he's got aphasia. It started an hour ago. So he comes in and you calculate up his NIH. And when I say that, I'm talking about the National Institute of Health stroke score, which if you aren't aware, you can do the certification online. It's completely free, and it helps you just be confident and go through these stroke patients and be able to communicate with your neurologist, your interventionalist, and all be on the same page. We kind of communicate through that NIH stroke score. So I won't go over that, but if you're not familiar with it, I would encourage you to get online and do that training so you are. So his NIH stroke score is a 17. His medicine list includes Coumadin, and he has his arm in a sling. And he tells you that he fell 3 weeks ago and he's got a humerus fracture. You call a code stroke, you order some labs, you order his CT scan, and his labs show that his blood sugar is 203, which is, according to the Stroke Association, the only lab that is necessary prior to administering IV-TPA. We can talk about that more if you want. And his INR, which you would order if a patient is on Coumadin. Otherwise, the only lab you would need is that blood sugar. But his INR, since he is on Coumadin, is 1.2. So you get a CAT scan, the radiologist calls and says there is no bleed. So I'd like to see, by a show of hands, who feels he is eligible, given this scenario, his labs, his presentation, for TPA. Does anyone think he is? I gave this talk to my residents yesterday, and I got a very low show of hands. So again, people, how many think he is maybe eligible, but you're hesitant or you feel uncomfortable giving this gentleman TPA? Okay, a little more people. So first we need to know, what are the inclusion and exclusion criteria? So, inclusion criteria, first, he's got a clinical diagnosis of stroke, okay? He does. Second, onset less than 4.5 hours. He definitely has that. He's within 1 hour. Third, age 18 or over. So these are the 3 things that you have to get TPA, but there's a whole bunch of things that you can't have to get TPA. So we're going to touch on these. So this is a huge list. I've listed this all in a handout in detail. These are taken from the 2018 American Heart Association guidelines. So I don't expect you to remember this or write this down. You don't need to. It's also on MD Calc, and it's on UpToDate. It's on a whole lot of sources. But I did want to highlight my pointer, this one right here. So our patient is on Coumadin, right? But his INR was 1.2. So we're in the green. The exclusion is an INR over 1.7. So this is not a contraindication for him. Now, I didn't give you his vital signs, but his blood pressure is okay, and he doesn't have any of these other things as well. I did star these last 3. If you look at the package insert for IV alteplase, those are the only 3 that are not exactly the same as the package insert. But this is the list according to AHA, UpToDate, all of those other sources. So these are what we call the absolute contraindications. Definitely wouldn't give TPA to any of those. Here's the relative contraindications. So the things that you should think about, but that won't exclude you from getting TPA. Again, this is a really long list. So on this list, I wanted to highlight one of these as well. So major trauma, but non-head trauma. Our gentleman broke his arm 3 weeks ago, but that is greater than 14 days. So it's something to think about. It's possibly something to consult with your neurologist about, but it's not an exclusion criteria for him. So technically, he doesn't have any exclusion criteria. So I specifically want to touch on these here. So relative contraindications. If you look right now on MD Calc on your phone, or if you use UpToDate, you will still see the term relative contraindications. The new stroke guidelines that came out in January of this year, they don't use any terminology. They don't use absolute contraindications, relative contraindications. They just specifically go case by case, and they say, if you're at 3 to 4.5 hours, it is safe for you to receive IV TPA. If you're over 80, it is safe for you to receive TPA if you're on anticoagulants, but your INR is less than 1.7. It is effective and reasonable for a diabetic and stroke history. And the only one they don't give a lot of endorsement to is this high NIH. So this right here is a change, because if you remember back when TPA was approved to be used from 3 to 4.5 hours, these were absolute contraindications. If you were over 80, you were out. You could not get TPA. This right here shows you can. So according to the new guidelines, those 3 and 4.5 hour guidelines kind of went away. So it may still be listed in some sources, which can be confusing, under the relative contraindications, but it is not a contraindication. So really that barrier to 3 to 4.5 hours is removed. It's pretty much just 0 to 4.5 hours now. So that's relatively new. So here, I wanted to pose a question for you. Say our gentleman, instead of being 94, was 34. Do you guys feel that you would be more comfortable giving thrombolytics to her with those symptoms if she came in with an NIH of 17? I ask this for a couple of reasons. One, because age is specifically referenced in the guidelines. And they say this: IV alteplase within 3 hours is equally recommended for less than 80 and greater than 80. And I just mentioned at 3 to 4.5 hours, it is considered safe. So they don't say equal, but they say safe. So I mention age because of that. It is mentioned in the guidelines. It's brought up in the guidelines because as you age, your risk for hemorrhage does increase. So we're going to talk about risks and how to look at patient characteristics and stratify them according to different characteristics that they have. So that's why I ask you about age. So my first tough question is, what is the risk of thrombolytics? If you have a patient that we just talked about, and you want to go and talk to him and his family, and you want to say, we have a drug that we can give you, we can treat your stroke, but I need to talk to you about the risks. I need to talk to you about the benefits. What do you say? Is it the same as if you were going to talk to that 34-year-old? It is different, but how different? What do you know? What do you say as a percentage? Historically, we like to use the number 6. 6% was the rate of symptomatic intracranial hemorrhage in the original NINS trial. Back in 1995, that was the trial that led to show the effectiveness of IV TPA in acute ischemic stroke from 0 to 3 hours. But there's a couple of problems with the number 6. I don't think we can just apply that to every patient for a couple of reasons. One, the definition of symptomatic hemorrhage in their study was this: it's basically any bleeding and any worsening in neurological status within 3 days. So you could maybe get sleepy, you could maybe increase your stroke score by 1. We don't know what the long-term impact of those changes in neurological conditions were. It may have been nothing. It may have not increased their disability at all. So it's over-inclusive. The other problem with that 6% is that it represents 20 people. 20 people out of 312 who had a symptomatic hemorrhage. So that's a pretty low number to base a broad statement on. So I think, and I've read all about these other sources that we can use to risk stratify. And I want to introduce you to a couple of those. First is the HAT score. And this is straight from MD Calc. So I saved it as one of my favorites, and I can use it easily, pull it right up. But basically, the HAT score was a scoring system that was based on a study published in the Neurology Journal in 2008. And what the authors did was a literature search. They looked at all the different data out there that showed what characteristics do increase your risk of hemorrhage when when receiving thrombolytics in stroke. And they made a 5-point scale using the top 4 factors with the highest odds ratio of causing hemorrhage. And they developed a scoring system. They tested it out first on the NINS data, and then they compared it with about 100 patients of their own at their own hospital. They did find that it correlated moderately well. They found it to be moderately reliable. Now, this score is not like the PERC score. It's not like the HEART score. This has not been prospectively validated on a huge number of patients. It is not meant to give you a yes or no answer. Yes, I'm going to give TPA. No, I'm not going to give TPA. But the good things that it does do for us is it gives us things to look at. It helps us know what factors do make people more risky when receiving TPA. And it also gives us some tools to help in conversation with your patients and discussing risk, because it can give you some numbers, some percentages. So as you see, if you have a HAT score of 0, you have a risk of symptomatic hemorrhage of 2% and a risk of fatal hemorrhage of 0. Versus a HAT score of over 3, your hemorrhage rate goes up quite a bit. It goes up to 44% for symptomatic and 33% for fatal. Again, this is a small study. It is limited in that value. The other limitation for this score is that it only can be used from 0 to 3 hours. So you can't use it in that extended treatment window. So we're going to plug our patient in and see what he gets. So he gets a point for his stroke score, and he gets a point for his blood sugar. Now, blood sugar is on there because as you have higher glucose, you have a higher permeability of your blood-brain barrier, which causes increased risk of bleeding into your brain. As you have a higher stroke score, you have more brain tissue involved that is unstable and more prone to bleed. So those two components are on here. So he gets a 10% risk of symptomatic hemorrhage and a 7% risk of fatal hemorrhage, as you can see right down here. So at 2 points, 10% risk. But this is what the authors say about their own score. It alone should not be used to withhold treatment, since most patients who have severe infarcts are destined for poor outcomes. So this gentleman at 94 has a debilitating stroke, and you have to determine, is the risk worth the benefit? If you do nothing, think of what this gentleman is going to be like down the road. It's probably not good. And 10% may seem high, but 90% is much higher. 90% risk of not having a symptomatic hemorrhage. So it's something to think about. Again, it's not perfect, and it's not going to replace just having a great conversation with your patient and just looking at them and their own personal risk. So the next score, you can use up to 4.5 hours. This one is called the Sedan score, based on the components. Sugar, again, same as the other one, early infarct on CT or hypodensity, a dense cerebral artery, which is different than HAT score, age is also different, and your stroke score. So this one is based on a study published in the Annals of Neurology back in 2012. Again, they looked at all the literature, they came up with a score, and they tested it out. They tested this over in Europe on about 3,000 people for this study, and then there was a massive external validation study of about 34,000 people. So this one was tested on a much higher number of people and found to be, again, moderately reliable. So not highly reliable. It does need more validation, but it is worth looking at. So this one, again, it has more components, and it has to be quick and it has to be easy for you to use when you're making decisions in stroke treatment anyway, which it is. This takes literally 10 seconds to plug this in if you're using this on your phone. So we're going to plug our patient into this one and see what he gets and compare it. So he gets a point for his age, a point for his stroke score, and a point for his glucose, which puts him at a Sedan score of 3. So this score gives him an 8.8% risk of symptomatic hemorrhage. The definition in this trial of symptomatic hemorrhage is according to the ECAS-2 definition. That trial led to the approval of TPA use in that extended window, 3 to 4.5 hours, and that definition is a little more inclusive or a little less inclusive than the NINS data. So in this definition, you have to increase your stroke score by 4 or more and have a bleed. So it's not any worsening, it's a significant change in your stroke score. So he has an 8.8% risk of hemorrhage. So I'm assuming you'd like to know what happened with our gentleman. He actually did receive IV TPA. His CTA came back showing a right middle cerebral artery and internal carotid artery thrombus. He was transferred to an interventional center and underwent a thrombectomy. He did not have a bleed. He did not die. But he did improve. He did not improve completely, but he did have some improvement. He had a modified Rankin of 1. He was able to follow some commands and speak in short sentences after his treatment, which was a big improvement from where he was in the emergency department. So the authors of this study say this quote here, which I wanted to show you. Although the scores may provide us with valuable information, your clinical judgment remains the basis for treatment decisions in acute stroke care. So that's really what I'm trying to get across today, and we'll come back to again. It's your judgment that's going to make that decision. So we're going to move on to our next case. 73-year-old gentleman who has dizziness and blurry vision for the past 80 minutes. He has on exam a left lateral gaze palsy and a subtle left facial droop with smiling. You total his NIH and it comes to a 2. You call a code stroke and he goes to the CT scanner. They call you and say, there is no hemorrhage. So how many of you on this one would even have a discussion or offer TPA to this patient, assuming on that long list he has no contraindications? Not many. 1, 2, 3 people. Okay, this is tough. This is a very atypical stroke. It's a posterior circulation type stroke, and his NIH is only a 2, which is why I wanted to include this case and what I want to talk about next. Because this is a patient that falls into the mild stroke category. He has a low NIH. What do the guidelines currently say about this? There should be no exclusion for patients with mild but nonetheless disabling stroke symptoms in the opinion of the treating physician, because there is proven clinical benefit. So they ultimately leave it up to you to determine, is this mild, but is it disabling? So how do we know what is a mild but disabling stroke? So that's what I want to talk about now. So this is a list of mild but disabling strokes. Okay, complete hemianopsia, you can't see out of one eye, or you have a visual field cut on one side completely. Severe aphasia, visual or sensory extinction, you're kind of not paying attention or feeling one side of your body. Weakness limiting sustained effort against gravity. So maybe your leg isn't completely flaccid, but you can't bear weight completely on it. That could make you disabled. You could not be able to walk normally or without a cane or a walker, or maybe not use your hand as normally, and it could limit you from working any longer or driving. Any potential deficit that you and your patient feel is disabling. So these are all things that could lead to you being disabled from things that you do in your life. So getting out of your home independently, being able to see enough to drive or work. So these are things that you should look for, and I've listed these in the handout as well, because these are really mentioned, these exact words and scenarios are mentioned on those up-to-date guidelines. So there are 2 barriers that we think of when deciding on treating mild strokes or low NIH strokes. The first one is going to be, we assume the risk of thrombolytics outweighs the benefits. We think, this is a really dangerous drug. We are going to cause life-threatening hemorrhage, and this person only has an NIH of 2. That would not be worth it. But I want to show you a study that shows that's not true. And this was published in JAMA Neurology in 2015, called Acute Ischemic Stroke and Thrombolysis. This looked at 6,000 patients with mild stroke, an NIH of 0 to 5. And they wanted to look at the outcomes after they received thrombolytics. They wanted to see how many people had a hemorrhage and how many people had a fatality in that group specifically. It was a large group. And this is what they found. Mortality rate was 1.3%, and their symptomatic hemorrhage rate was 1.8%. So that's much lower than that 6%. And remember back when we were talking about the scoring systems, as your NIH increases, your risk of hemorrhage increases. So it appears the inverse is true as well. Low NIH, lower risk of hemorrhage. This study also shows that we disprove this barrier. We assume these patients with mild strokes have good outcomes. It's a mild stroke, they'll be okay, I'm sure they'll be able to live like this, no problem. But the people that were in that study, those 6,000 people with a mild stroke, even after treatment, 30% could not walk independently, and 30% could not be discharged to home. They had to go to rehab or a skilled nursing unit. So these people had some very big changes and very big disability. So TPA should be recommended on the disability, not the number, not exclusively on the stroke score. So think and look at the patient and look at what the disability is, and if they want to live or would want to take the risk of TPA or just living with that deficit. So that's something to think about. So our patient actually had a left vertebral artery thrombus, and his MRI actually showed a stroke in the left occipital and right cerebellar region. He did get TPA, and his repeat NIH stroke score on day 2 was a 0, and his symptoms resolved. So he had a good outcome, He had no bleed, he had no fatality. Him and the doctor that took care of him had a risk-benefit discussion about this deficit, and they felt it was disabling, his deficits that he was experiencing, and the patient wanted to undergo treatment with TPA. So, similar to this, what do we do with the patients that have rapidly improving symptoms? So they had one set of symptoms, but they seem to be much better. This historically was also an exclusion criteria, but is no longer. It's something to think about and consider, and this is what the Heart Association tells you. They say it's reasonable for those patients to be treated if they demonstrate early improvement, but remain impaired and potentially disabled in the judgment of the examiner. So they leave it up to you. So how do we know if they're still disabled? We just talked about what disabilities could lend to permanent bad outcomes or disability long-term. This study here was published back in 2007, so it is older, but it was done at a time where this was an exclusion criteria. They did the study because they wanted to take that away as an exclusion criteria. They wanted to see how these patients did. The last study we talked about, the patients were treated with thrombolytics. This study, they looked at patients with mild symptoms or rapidly improving symptoms that were not treated, and they wanted to look at the outcomes. So they started out with about 900 patients, 600 of which were not treated for one of the exclusions. 162 were excluded because of mild or rapidly improving symptoms. 123 was mild and 39 was rapid improvement. So a drop of their NIH of 4 or more. So they had significant improvement. They wanted to see how did these patients do? And again, 25% had an unfavorable outcome. They went through and they showed that of these 25%, here were the percentages on their modified Rankin score. So 16% of them had mild disability. So they could still basically function, but they couldn't do things that they did before, such as driving or working. 7% of those had a modified Rankin of 3 or 4. So that means they couldn't take care of themselves as far as bathing or going to the bathroom alone or walk independently any longer. And 1% ended up dead or bedridden. And then they broke it down even further and they looked at that rapidly improving group. And they had 2 strong findings. One was that if they started with an NIH of 10 or more, but they had significant improvement, so they dropped by 4 points, they seemed a lot better, and they did not get TPA. But if they had started at an NIH of 10 or more, they had a 17 times higher rate of unfavorable outcome. The second was if they had a proximal vessel occlusion, they had a 7 times higher rate of an unfavorable outcome. So I mention these because if you have a patient that is improved, but they started out at a 10 or more, you should really look at those patients hard and watch them carefully, because those are patients that likely will have an unfavorable outcome or a high chance of that. And we know that patients with strokes do have crescendo, decrescendo symptoms due to kind of intermittent blood flow, blood getting through and then not getting through. So they can have some improvement and then worsen again. I've seen it multiple times, patients that are admitted, and at the time of admission, they seem much better, so we don't give TPA. But when they get upstairs to their room, they get worse again and they have a devastating deficit, and at that time, you're behind the ball game. You've lost a lot of time in treating them. So we're gonna look at our last case here. It's a 79-year-old female who has slurred speech and aphasia. Her NIH is a 7. Paramedics brought her in, and you do a code stroke, and they tell you she started having symptoms 1.5 hours ago. She goes to the CAT scan, she comes back, and her family arrives. So you interview them, and they tell you, well, no, doctor, the last time anyone saw her normal was 12 hours ago. So now this changes things. She cannot receive TPA anymore. She's outside the time window. She's 12 hours out. She has what we would call a wake-up stroke. So this leads me to my last tough question for you. what is the treatment for wake-up strokes? So over the past year, since November of this year, when this DAWN trial came out, we've had some groundbreaking news and treatment in stroke care. This is really changing the way that strokes are treated, and I'm sure that there's more to come in the next few years from this. But for now, we're going to talk about what we can do with wake-up strokes right now. So this DAWN trial looked at patients that were 6 to 24 hours out from stroke onset. So they were outside the window for IVTPA, but they wanted to see if in the right patients, so patients with a large vessel occlusion, either MCA or internal carotid, and that had a salvageable area of tissue on their perfusion scan, how well they would do after a thrombectomy compared to usual stroke treatment. So usual stroke treatment being we get them admitted to the hospital, we give them their aspirin, we treat their swallow study, we give them anything they need, statins. And they found that compared to usual treatment, the patients with those large vessel occlusions that had salvageable tissue and got a thrombectomy had a 49% rate of functional independence at 3 months versus 13%. They did significantly better. They stopped the study early because of this, because patients were doing so much better. They couldn't justify continuing to place patients in the usual treatment care group. So what you need to know about this is who is eligible at that extended window, 6 to 24 hours, for thrombectomy. And this is the criteria. So thrombectomy is done at a comprehensive stroke center. You need to have interventional neurologists there. So they're going to want to know for sure that the symptom onset was less than 24 hours, that they have a large vessel occlusion. Any of these, anterior cerebral, posterior communicating, internal carotid, middle cerebral, or basilar artery, are considered possibly treatable. And they need to have a significant deficit. So this generally means an NIH stroke score of 6. So that's another reason why I encourage you to get familiar and practiced with that stroke score, because they're going to want to know what their stroke score is. This is the general rule, but if a patient has a devastating deficit and their stroke score is a 5 or something like that, I would still call, I would still push to have them seen and evaluated to see if they have eligibility to be treated. They also have to have penumbra on their CT perfusion. So once you determine they're inside the time window, they have a large vessel occlusion, they have a significant deficit, you send them to the comprehensive center, they're going to need to see, is there anything to save? So they're either going to, here in Oklahoma, I think everyone's doing the CT perfusion scans to see if there is a mismatch, if there's area that they can save. If they meet all those criteria, then they can undergo thrombectomy. The other key piece of information that our comprehensive center wants to know is that the patient actually has a baseline functional status. So patients that are on hospice or have a severe chronic illness or that are bedridden, those are not patients that are generally accepted to be transferred and done, have advanced neurological procedures done on. So these are patients that actually have a somewhat normal life before the procedure. So our patient that we just saw had a posterior communicating artery occlusion. Remember, she was at 12 hours out, so that's quite a bit of time. But they sent her for thrombectomy, and she achieved good flow from that thrombectomy. She still had a large area, even at 12 hours, she had a large area of penumbra, and she had significant improvement after her thrombectomy. So that was a great save. So if you don't have access at your shop to a CT angiogram to look for that large vessel occlusion or an MR angiogram or however you would normally do that, You can use a clinical bedside screening that I wanted to mention, and you can look this up online. They have a website that shows you the study. It shows you a little training video. It shows you a paperwork you can actually use with check boxes. It's a screen. It's not a score. It's a yes or no answer that takes about 15 seconds. And paramedics around our area in Norman are already using this to make decisions on who do we take to the comprehensive stroke center like right off the bat. Because some people, it's better for them if they present in a certain time frame to actually go straight to the comprehensive center versus first going to a primary center to be evaluated. So this is really kind of on the horizon, this screening tool right here. So this tool can be used like in the ambulance or by nurses. Really, it's easy. You have to have some weakness to screen positive, first of all. If you don't have weakness at all, you aren't going to have a positive screen. So you have to find weakness in one of their limbs plus something else on here, a visual disturbance, aphasia, or neglect. And when they did the study, although it was small, 62 patients, it was 100% sensitive and 90% specific. And now they're doing a bigger validation study using this. But it's something to keep in your mind if you don't have access to those CT angiograms at your shop, maybe in the middle of the night or something like that. So, just to summarize, we talked about a lot of things. We did talk about risk factors for bleeding and poor outcomes, increasing glucose, increasing stroke score, age, and CT changes. We talked about mild and rapidly improving symptoms, how they can sometimes have not mild outcomes. They can have potentially devastating outcomes, and how thrombolytics in those patients actually has been proven safe. And we just spoke about who qualifies for treatment up to 24 hours. And bottom line, what I was trying to get across today is that your judgment, knowing these guidelines, knowing how to do a good exam and make decisions with your patient is going to determine the best course of action for your patient and whether they should receive treatment with thrombolytics, thrombectomy, or both. So I will be happy to entertain any questions if anyone has any. These are my references as well.